only mode.
Hello and welcome to the TVN Webinar Series. I'm John Muscaderi. I'm the Scientific Director for TVN, and this is our monthly webinar series where we present insights and advancements on research for caring for frail elderly Canadians. And in the past couple of months, we've been looking at the outcomes of TVN-funded knowledge synthesis grants, and today's continues along the same vein. Our presenters today are Richard Sawatzky and Eric Chan, and I will introduce them shortly, but their presentation today is patient and family reported experience and outcome measures for elderly acute care patients. So Richard Sawatzky is Canada Research Chair in Patient Reported Outcomes and Associate Professor of Nursing at Trinity Western University. He has a clinical background in palliative care and medical nursing care, and his research focuses in patient-reported outcomes, quality of life measurements, and the intersections of spirituality, religiosity, culture, and other sources of diversity in various healthcare contexts. Eric Chan is a TVN Interdisciplinary Fellow who is under the supervision of Dr. Sawatzky. He has received his PhD from the University of Calgary and has done postdoctoral work at the University of British Columbia, and his research focuses on patient-reported outcomes, including psychometric patient-reported outcome measures and patient-reported experience measures. So as you can see, our presenters today are highly qualified to present on this, and look forward to the presentation. Just a housekeeping issue, and in regards to question and answers, everybody's microphone is muted just to reduce the amount of noise during the presentation. But please submit your questions online during the webinar using the chat function. We'll aggregate the questions. We'll look and get to as many as possible at the end of the webinar. We expect to leave 10 to 15 minutes for questions, so please submit as many questions as possible. For questions that we do not get to, we will we'll try to post them online afterwards. But without further ado, I'll turn it over to our presenters, Richard and Eric.
Great, thank you for the introduction. It's Richard here, and Eric is with me in the room. So we're going to have a discussion about patient and family reported experience and outcome measures, focusing on older adults in acute care. And we're going to report the results of a knowledge synthesis that was funded by TVN and involves several HQPs and trainees and researchers and healthcare administrators. So what I'm going to do is first give you a brief background on patient-reported outcomes and experience measures, just so we're all on the same kind of foundation, because there's different degrees of familiarity. And then Eric is actually going to talk about the methods and results of the knowledge synthesis. And then I'll come back with some concluding comments. And as was mentioned, we really welcome questions. Try to address them as much as we can following the webinar, but or as part of the webinar, but also feel free to contact us after the webinar. I'll share you my email address and be happy to have further conversation. So I'll go to the next slide. So this is, I'm just going to give you this up front here, that we are going to be presenting on this knowledge synthesis that was conducted in the context of a fairly large team for a synthesis involving researchers from BC and McGill and the University of Alberta and the University of Victoria, University of British Columbia, We had a library scientist involved, Duncan Dixon, of course, for constructing and conducting the searches. We had knowledge users involved from the Ministry of Health and from the Health Authority, one of the largest health authorities in the province here. We had trainees involved, undergraduates, graduates, and postdoctoral. We had several research assistants involved as well. Two of them are actually now HQPs on other TVN projects. So just, the objectives for today, like I said, I'm going to provide some background first of all to build some familiarity with patient-reported outcomes and experience measures. As part of the presentation of the results of the knowledge synthesis, we're going to learn about the characteristics of PREMs and PROMs used in acute care of older adults and their family caregivers. And then we're also going to review some important measurement validation considerations as a foundation for selecting and using PROMs in that population. So just by means of background, our work is grounded in the recognition that the perspectives of patients about their outcomes and their experiences with the care provided are foundational to the provision of patient-centered healthcare services. As articulated by Gertz, from a patient-centered point of view, and as a leader in patient-centered care affiliated with what was the Picker Foundation, our aim should be to find out what each patient wants, needs, and experiences in our healthcare system. And this perspective is important for all areas of care, but it's particularly important for older adults, especially those who have life-limiting conditions, and especially as those conditions progress, where the goal of care increasingly becomes focusing on quality of life rather than cure. So we also know that it is important to pay attention to the outcomes and experiences of family caregivers who play an important role in the care of older adults. And so we need to consider that they are both providers and recipients of care, and that their outcomes and experiences need to be taken into account as well. In order to ensure that the care addresses the needs of both patients and family caregivers, we need to find ways of making sure that the care is informed by both their perspectives of their experiences and needs, and also by other kind of performance indicators and clinical outcomes. And so that's what this little diagram shows here, where we have patient-centered care, which needs to be informed by patient and family experience of the care provided, and also by their outcomes. And that includes both, the experience includes both kind of the typical performance indicators like wait time and access to care and so on, but also their perspectives of the care provided, like communication with healthcare professionals, so they get the information they need, and so on, from their points of view. But similarly, for patient-reported outcomes, of course, we have patient-centered clinical outcomes that are very important, but we also need information about patient and family perspectives of their outcomes and their quality of life. And so this is where patient-reported outcome and experience measures play an important role. PROMs and PREMs, as it goes, I actually like to refer to them as person-reported outcome and experience measures, because that would more logically include family as well, because there's measures for both patients and family, but the typical term out there is patient-reported outcome and experience measures. And so these are standardized measures that provide information about patients and families' perspectives of their quality of life and their healthcare experiences. And the idea is here that we get this information without any interference of a clinician or any other person. So it's supposed to be kind of unmediated information. It will be explained a bit more on the next couple of slides. So in terms of patient-reported outcomes measures, again, it's important to get the recipient's appraisals of their health status from their point of view. These measures are typically multidimensional in nature, in that they address are various domains of human experience, and that includes symptoms in health, in the context of health. That includes symptoms, functional status, but also aspects of psychological, social, and even spiritual well-being. PROMs also provide information from their perspectives about their health and quality of life, as mentioned, without interpretation, prior interpretation of a clinician or any other person. There's many frameworks out there for the measurement of PROMs and PREMs. Here is a framework from the Patient-Reported Outcomes Measurement Information System, which has been funded by the NIH for over 10 years already. It's a very, very large initiative. And they have they built kind of this framework for organizing their patient-reported outcomes measures. They have a whole database of items, thousands of items actually, that can be used to assess these type of domains like physical health, mental health, social health, and under that there's subdomains of functioning under physical health and symptoms and fatigue, and under mental health, depression and anxiety, and social satisfaction with social roles and so on. And then there are additional domains beyond that, and actually the framework goes on quite a bit further. I encourage you to go to that link and you could have a more detailed look at that. This is a very large initiative that I thought it would be helpful for you to be familiar with. But there's other frameworks of thinking about patient-reported outcomes and what they measure. For older adults, one that's particularly relevant and has been around for a long time is the Functional Assessment of Chronic Illness Therapy Measurement System, which is a collection of tools that assess physical, social, emotional, and functional well-being, and that focus then more specifically on quality of life, whereas PROMIS focuses more explicitly on health. The facet measures focus more generally on quality of life, which encompasses health, of course, and specifically in relation to people with chronic illness. And they have different tools for different disease populations. So people with particular conditions, you have tools for people in palliative care, for instance, and so on, renal care. So what do these instruments typically measure? I showed you the framework, and as I kind of suggested in the previous slide, there's generic measures and there's disease or condition-specific measures. Generic measures are meant to be applicable to a wide variety of populations, not disease-specific populations. And there's a lot of measures out there. In fact, there is the ProQual database indexes nearly 800 measures that have been made available, and there's many more than that. So here is a selection of several instruments that we reviewed. I should have provided the publication here. I can send you the publication if you want, but it was done to guide the ministry, provide some guidance for the ministry here on the selection of a generic health measure. But why I'm showing this is that it provides a bit of a sense as to how the measures are similar and different. They all tap into similar types of domains like social, mental, physical in general, but you can see that the relative representation domains of in terms of the number of items, which is what the stacked bars are, is quite different. So some instruments focus more on physical health, for instance, and others have more of an emphasis on mental health, and others include more social symptoms or considerations, and others include more of a focus on symptoms. There is also disease-specific measure, one that is quite relevant in our population of people with chronic life-limiting illnesses or frail elderly. People with serious illness is the McGill Quality of Life Questionnaire. As you can see, it looks a little bit different. It again has the physical and psychological domains. It's the social domain is conceptualized more of a domain that pertains to relationships, so it's a slightly different label. And it also includes an existential domain because of research that has revealed that existential considerations are quite important in this population as well. And so this is a 14 questionnaire with 14 questions, and people are asked to respond to them on a 10-point scale. There's also patient-reported experience measures, and those measures ask people to focus more on the care that they have received. So whereas patient-reported outcomes measures focus internally, patient-reported experience measures tend to focus externally. And so they get at domains related to access of care, coordination of care, emotional information, support, and so on. And similarly, the idea is to get their perspectives without prior interpretation of a middleman, in quotation marks. Again, there's different frameworks of patient experience. One of the widely used one is the one by the Picker Institute. And it covers these domains: respect for patient values and preferences, their information, communication, and education, coordination of care, very important, including transitions of care, involvement of family, emotional support, physical comforts, and so there you see a little bit overlap with a PROM. They're not quite as distinct as we might think them to be. Preparation for discharge and access to care. There are some other models, like the model for patient and family-centered care, which has similar domains, but focusing more on respect and dignity, information, collaboration, and participation. And I also provide here the IHI model, which on achieving exceptional care experience. You can see there's also similar domains. But these frameworks come from different points of view, informed from with different objectives in mind. Though there are quite a few generic PREMs out there, there's also, again, condition-specific PREMs. One that is of particular interest to the older adults, frail, elderly, and particularly focusing more as the disease progresses and as end-of-life care considerations become increasingly important, is the Canadian Healthcare Evaluation Project, the CAN HELP, that some of you may be familiar with, developed by Darren Hayland and his team. And it assesses domains to do with relationships with care providers, illness management, communication, decision-making, and feeling of peace. The number of questions noted here for the CAN HELP Lite. There's also a larger version that includes more questions and provides more detail. And you can see an example of the questions there. So again, people are asked to rate these questions, and then a score is produced. So what do we do with this kind of information? There's actually a long history of use of PROMS and PREMs. They've been around for over 40 years. There's several systematic reviews about their use in care for health services decision-making, their use of points of care, and also for economic analysis. So it's actually not that new necessarily, although their uptake has been somewhat limited. But they're used for a variety of reasons, and important to keep that in mind. They're used by health professionals at point of care, so to inform treatment decisions, to monitor patients' conditions, to promote communication with patients, and to ensure that their health and quality of life concerns are assessed, especially those that may otherwise not have been noticed. They're used by health researchers to evaluate the effectiveness of treatments and the impact of healthcare interventions, and to understand the impact on patients' daily lives from their point of view. Also used by health service decision makers for quality improvement and for comparative analysis of health service delivery programs and cost effectiveness analysis. And increasingly, they're actually being used by healthcare recipients as well. PROMS and PREMs we're beginning to integrate them into electronic health records that are actually being managed by the healthcare recipients themselves. And as part of that, they could complete a PROM and PREM, print out a report, and bring that to their care provider to kind of help communicate their primary concerns and monitor those. Despite all these potential uses, there are challenges. We know that there is significant interest in these instruments to inform patients and family-centered care. We know that there are many PROM and PREM instruments available. As to our last count in total, there's about 1,200 available, and we'll find out pretty soon how many are available for older adults, quite a few actually. But people need information to determine which instruments to use and how to use them for their best purposes. And that is what our knowledge synthesis was about. And this is what Eric is going to present on. So I'm going to hand this over to Eric. And he's going to present on the results, methods and results of the knowledge synthesis.
Hi everyone, it's Eric Chan here speaking. Thanks Rick for providing an overview of PROMS and PREMs, and thanks also for TVN for funding this project. What I'm going to do next is to present on the method and the results of our knowledge synthesis. And the area of PROMS and PREMs is really an interesting area to get into. Over the past 2-3 decades, I would say. We've seen an exponential increase in the number of PROM and PREM instruments published in the academic literature. So clinicians, researchers, and knowledge users really need some guidance in terms of selecting and using PROMs and PREMs for their work. And we really need to have a central source, a central database, if you will, with all the information of all the PROMs and PREMs for this patient population. So that's really the motivation behind this knowledge synthesis. So before I get into the details of the method of the results, I'm going to provide you with an overview of the project. So it's a relatively big project, I would say. Had 3 stages. So in stage 1, the purpose was to search and to compile a list of all the PROM and PREMs instruments for this patient population, and to collect basic information regarding the characteristics of the instruments. And then in stage 2, we focused on a smaller number of instruments, and we collected a detailed information regarding the measurement characteristics and administrative characteristics. And then moving on to stage 2, we focused on evaluating the psychometric properties of the instruments with published psychometric validation evidence for this patient population using commonly used standardized evaluation tool. And I'm going to get into the details momentarily. So this is an overview of the search strategy. So you can see we covered a number of databases as well as other sources such as PROPOLIT, which is a database developed by a group of people from Europe. And we also consulted with experts in the area. We sent a survey out to people, making sure that we didn't miss any instruments. We looked at the review articles and reports and other published handbooks, etc. So I'll get into the details. So in stage 1, the purpose was to compile a list of all the instruments available out there. So we did our search using databases and the different sources that I just talked about, and we developed and applied selection criteria, including that the instrument had to be a PROM or PREM, had to be used in older adults over 55 years of age, and the instrument had to be administered in an acute care setting. So the purpose of stage 1 was really to collect basic information about the instruments, and we had a total of 186 instruments that had been used in this patient population, and that met our inclusion criteria. So we collected all the basic information, including the type of instrument, such as whether the instrument is PROM PREM, the dimensionality. I mean, some instruments are unidimensional, meaning that they only measure one domain, whereas others are multidimensional, they cover more than one domain. And also the different dimensions measured by those PROMs and PREMs. So these are basic information, and we collected all of these for the 186 instruments that were included in stage 1. So as you can see on this slide here, of the 186 instruments, 136, the majority of them, were patient PROMs. And of the 136 instruments, 67 of them were disease or condition specific, and about 50 of them were generic patient PROM instruments. Compared to PROMs, we did not find very many PREM instruments, and some instruments were for both PROMs and PREMs. We also didn't find too many instruments for that category. And since we are focusing on frail elderly patients, we thought it would be interesting to present some information regarding the different disease or diseases or conditions for the different PROMs. As you can see on here, we found quite a number of PROMs, patient PROMs designed for the cancer population as well as the palliative care population. We were not able to find too many instruments for Alzheimer's disease or dementia. And as you can see on the slide, we didn't find any PREMs for condition-specific PROMs for this patient population. So here you can see on the slide that we are presenting on the different domains that the PROMs and PREM instruments measured. Right on the left-hand side of the screen, we are showing you the different dimensions for PROMs, including overall health, general health, physical functioning, physical symptoms, mental health, social health, and other dimensions. And for PREMs, the instruments covered like information and education, coordination of care, physical comfort, emotional support, respect, family involvement, continuity, overall impression, and access to care. So, building on our results, stage 1, in collaboration with our knowledge users, we developed and applied additional criteria, and we collected detailed information on those instruments. So as you can see on the screen, that the additional criteria that we developed and applied in stage 2 included for PROMs, we only included generic instruments, and we only included multi-dimensional instruments that measure both physical health and mental health. And since in stage 1 we did not find very many family caregiver PROMs, we decided to just include all of the family caregiver PROMs, and we also included all instruments developed for palliative or end-of-life care. Similarly, for PREMs, we included PREMs that were multidimensional, and we included all family caregiver PREMs and instruments that were developed for palliative or end-of-life care. So for in stage 2, we collected information on the PROMs and PREMs regarding the scoring procedures, scaling information, mode of administration, response burden, as well as all the different language versions that were available. So as you can see on the slide here, with respect to the scoring procedure, the majority of the instruments had some kind of total scoring procedures, whereas some other instruments, they provided some kind of domain scoring. And for scaling, almost all of them, well, the majority of them use some kind of Likert scale. And with respect to the mode of administration, many instruments were paper-based. Some of them were available for some kind of telephone-based or interview-based mode of administration. And with the advancement in computer technology, we are seeing many more instruments that are available via computer or a web-based, tablet-based type of mode of administration. So we're actually seeing a wide variety of administration modes. One of the important things for using PROMs and PREMs in clinical practice is a response burden. As you can see on the slide here, most of the instruments that we found were relatively short. Most of them, or the majority of them, had between 11 and 20 items, and most of them can take approximately 10 minutes to complete. Translations. Well, first of all of the instruments that we found were available in English. Oh, by the way, in stage 1 we had 186 instruments, and then we applied additional criteria in stage 2, and from the 186, 88 met our inclusion criteria. So in stage 2 we had a total of 88 instruments. So all of the 88 instruments are available in English, and many of them have been translated into French and some other different languages such as Chinese, Farsi, Korean, Punjabi, and Tagalog. Now it's important to point out that although the instruments have been translated into a number of different languages, we did not find a lot of empirical evidence in terms of the validity of the translated version. So we are actually not sure how valid those translated instruments were. So in stage 3, the focus was to evaluate the psychometric properties of the PROMS and PREMs with published psychometric validation evidence for this patient population. So what we did was, building on the results from stage 2, we developed and applied additional screening criteria, including that the instrument had to be, or that the paper had to be a validation study, focusing on older adults and in hospital care setting. So we did a search on PubMed using a search filter called COSPIN, which is a group of researchers from the Netherlands, and they developed this COSPIN search string specifically designed for searching for measurement studies on PubMed. So we applied that COSPIN search string to search for psychometric papers. And with respect to the evaluation of the psychometric properties, we used the MPRO, which is a published, quite commonly used evaluation tool for evaluating psychometric properties of self-report health instruments. And it covers a number of domains, as you can see on the right-hand side of the screen, including the conceptual and measurement model, the reliability of the tool, the validity of the tool, responsiveness, interpretability, response burden, alternative modes of administration, if there's any, as well as the cultural and language issues. So, after applying all those screening criteria, we were able only to come up with 2 instruments, well, 2 instruments, 3 versions, including the Can Help and the Quality of Dying and Death questionnaire. And for the Can Help, there are 2 versions, the Can Help, which is the original version, and then the short form of the Can Help, which is the Can Help Lite, developed by Darren Halen at Queen's University, which Rick mentioned about early in his presentation this morning, or this afternoon for those of you in Ontario. And then the Quality of Dying and Death questionnaire is also included in stage 3. So we applied the MPRO evaluation tool to evaluate the psychometric properties. And as you can see on the screen here, the Can Help and the Can Help Lite did pretty well. They scored pretty high on a number of domains covered in the MPRO, and however, for the QODD, that instrument did not score very high. The recommendation by the researchers who developed the MPRO suggested that if an instrument scored over 50, it's considered as an acceptable instrument. And as you can see here, the Can Help scored about 50 on the overall score, and you can see in some of the areas they actually scored very high. So we believe that they can help possess pretty good psychometric quality, and it can be recommended for use in this patient population. However, for the QODD, with respect to its psychometric, it's not as good compared to the can help. So with respect to the discussion summary, we found a large number of instruments, for example, that have been used in this patient population. Many of them are generic, and many of them are condition specifics. Although we have found a large number of instruments, not very many have been validated for this patient population. Like, you take a look at the stage 3 results, we were only able to find 2 instruments with published psychometric validation evidence for use in this patient population. So more validation studies are needed. So building on this study, I am currently working on my fellowship project, which is a Delphi study with an eye towards developing some consensus-based, evidence-based recommendations for the selection and use for PROMS and PREMs in this area for this patient population. So, which aligns very nicely with the findings of this knowledge synthesis. So, I'm now turning it back to Rick.
Yeah,
for some concluding comments.
Great. I'll just thanks Eric for an overview of our projects. Great work. And I'll just add a few minutes of considerations, concluding comments, particularly focusing on measurement validation. You will have noticed from the presentation that there are actually remarkably few validation studies out there that specifically focus on older adults. There's many validation studies of these instruments, but that doesn't mean that they're valid, that the information they provide is useful and appropriate for older adults. And so there's a great need there. I'm often asked by people about consulted regarding the selection and utilization of PROMS and PREMs for this population, and they often ask me, which instruments should we use? And my response is typically, well, there's a few other questions that we need to consider first. Let's not start there. And together, as part of some consulting work that I did with the Canadian Institutes for Health Information, you could read their report online if you wish, or initiating a pan-Canadian PROMS and PREMs initiatives. We developed this framework to help guide people. So what do we need to consider when selecting and utilizing patient-reported outcome and experience measures? And first of all, we need to be very clear about the purposes for collecting the information and how we're going to use the information. We need to do that before we actually look at what information we're going to collect and which instruments are best for collecting that information. We also need to consider the administration of these tools. What is their mode of administration? What are the languages that we want them to be available in? And or should they be administered cross-sectionally at one point of time, or do we actually need a before or after or a longitudinal kind of evaluation? And then we need to consider the utilization of these instruments, PROMS and PREMs, I should add to the diagram here. So the take-home message here is that the decisions about the selection and utilization need to be guided by evidence that substantiates the inferences that we want to make based on those scores. This is the kind of the technical take-home messages. What it means is that we need to have a clear sense of the purpose and the reasons for collecting this information. And as part of that, we also need to keep in mind that there might be personal and social consequences that we may not have been aware of resulting from the use of these instruments. And as part of that, we need to consider that each of these instruments, the hundreds of instruments that we reviewed, actually represent different underlying values, different conceptualizations of health and quality of life, and different, they're created to achieve different goals. And this links to a modern view of measurement validation that our program of research is focusing on. And I bring it up here because measurement validation is often kind of put to the side, not considered as like a foundational concern when selecting the instrument, but it's actually really important. And I think one of the reasons for it is that we haven't done a very good job of linking reliability and validity information to the actual purposes for which we want to use these instruments. And so there are new ways of thinking of measurement validity out there, originating from psychology and educational testing, that are slowly becoming, entering into this world of patient-reported outcome and experience measurement. The review that we've seen, even the MPRO, although it's, it's fairly advanced instrument, it still represents a fairly traditional view of measurement validation. A more modern view focuses on validation as an integrated, evaluative judgment of the degree to which evidence and theory supports the adequacy and appropriateness of interpretations and actions based on these PROMS and PREMs scores. So it's very much focused on what do we do with the information. When we consider that in the context of health, at a very generic level, we typically want to compare different people. That might be different groups of people, or it might be even comparisons of the individual level. And so for those different purposes, we need different types of evidence, different types of validation information to substantiate that type of inference. We also may want to make comparisons over time, maybe before and after a treatment, or maybe an evaluation of trajectories over time. Again, so these are kind of three foundational considerations in measurement validation that are emerging right now in validation theory. And the third one is about the consequences. What are the value implications, including personal societal consequences of using PRO and experience scores? So there is a whole program of research surrounding these three areas, and a great need in our world to consider these things. They haven't been widely addressed so far in patient-reported outcome and experience measurement literature. Finally, as you may recall, the fourth bottom piece of that diagram that I showed 2 slides ago is about the utilization. There's another very important consideration. We can't just come into settings and integrate a PROM. We need to integrate all of our stakeholders and knowledge users, decision makers, patients, family caregivers, clinicians, and researchers all need to come together. So shown previously, they have different objectives, different purposes, typically for collecting PROMS information. And so that all needs to be considered when working towards a strategy of integrating PROMS and PREMs. And so we're working, we have 2 projects running right now that involve the use of this type of an integrated knowledge translation approach, where we work with teams to actually first figure out what the problem is from their point of view, and then figure out, based on our synthesis and results, adapting that knowledge, figuring out a way to integrate and use PROMS and PREMs. And one of the ways in which we do that is through the use of what we've developed, worked with an information technology partner to develop a quality of life assessment and practice support tool. That's one way that came directly from practice and administrators to link patient-reported outcomes at the practice level with administrative and research use of these scores. And so within that system, patient-reported outcomes are administered at point of care. The clinician hands over a tablet, people complete a few questions, and then they get a report back about what their dominant areas of concern are and how they have changed since a previous assessment or multiple previous assessments. And then that information sparks a further, of course, in-depth assessment about those concerns and needs. And at the same time, it's fed into electronic medical health records. So there's great potential there. And that's all part of another presentation. So hopefully there'll be opportunity to share the results of those projects with you that are currently in progress. I just want to bring to your attention as well that there's an international society that's doing a lot of work in this area. They've been around for quite a while. And they're actually coming to Canada, to Vancouver, the International Society of Quality of Life Research. And since I'm part of their board, I feel I should share that information with you. So thank you very much. I leave again with the quote that we started off with. Our aim should be to find out what each patient wants, needs, and experiences in our healthcare system. And I look forward to your questions and comments during the next 15 minutes. And also feel free to contact us after this webinar if there's anything you want to discuss. I'll just close with one thing, that we do have a whole database of all those 100 and how many were they, Eric?
186.
186 instruments with all that information tabulated, including their references and so on. And so we're happy to share that with anyone, of course. So feel free to contact us about that. We also have a final report that's published online that gives you a lot more detail on what's been presented today. And our actual journal publication is in progress. So thank you.
Thank you, Rick and Eric. That was a very informative presentation. I have some questions for you, and the first one is for Eric. Are there any guidelines regarding use of PROMS and PREMs for older adults?
Thanks for the question. That's a very good question. Well, the answer is no. Well, there are guidelines published for the selection and use of PROs, of PROMS and PREMs in general. For example, the US FDA has recently published some guidelines for the selection and use of patient-reported outcomes. They focus particularly on PROMs, and it's now a requirement for industry to submit data for approval for labeling claims, and that's the U.S. And in Europe, the European Medicines Agency have also published a similar document for the use of PROMs for submission for approval. There are also several published recommendations, I would say, for the selection and evaluation of PROMS and PREMs. For example, the Cosmin, in addition to the Cosmin search string that they developed, the Cosmin group also developed a Cosmin checklist for the evaluation of the measurement properties of PROM and PREM instruments, and the MPRO, it's also another tool for the evaluation of PROM and PREM instruments. But based on the research that we've done, to the best of our knowledge, I don't think there's any published guidelines or standards or recommendations for the selection and use of PROMs and PREMs for this patient population. So no is the answer.
And that's why you're conducting
that's why I'm here, exactly.
Delphi study, right? So, yeah.
Okay. The next question is for you, Rick. Could you tell us more about the QPFF system, and is it freely available?
Oh, that's a great question. I didn't anticipate it, but that's great. Yes, so that system is developed in partnership with Integrate, which is an information technology company, and another partner has joined that as well, called Cambion. And Cambion is electronic medical record integration, a mid-size EMR integration company. And so they're going to help us kind of achieve that integration component. At this point, it's a standalone system that has full integration capacity, but the actual linking of that integration, of course, depends on what the systems that it integrates with. So what it is it's a tablet-based platform that's undergone kind of the typical privacy and security reviews and requirements, which I might add was a 3-year process. It is quite as you can imagine, we're collecting a lot of private information, and so the security requirements are extremely high. But it's a tablet-based platform that can be used in hospital settings as well as in community settings. So we have 2 projects running right now. One is in an acute tertiary palliative care unit where these tablets are being used, and the other one is in a palliative home care setting where these tablets are also being used. We work with the team to first of all determine which instruments they want to include on the tablets. And so the tablets can accommodate any typical patient-reported outcome and experience instruments. So they just need to be programmed in, which is quite straightforward. So the tablet system is actually like an empty shell that can be molded for the particular care environment. So it's really important that it works that way. We have a lot of, it's quite a history now of pretty much failed EMR attempts, which have taken a more top-down approach in which a system has been developed and then simply implemented without sufficient input. This system is developed to take a bottom-up approach in which it's developed and kind of adapted within each particular context. And so, in addition, we work with the teams of each setting to figure out what kind of reporting back features they want. So it gives live reporting back. So as soon as people have completed the instrument, it's scored, and the clinician gets a report back about dominant areas of concern and how they have changed over time. And at the same time, the information is automatically entered into an electronic database that can be linked with electronic medical records and so on, and used for health administrative evaluation purposes. So that's in a nutshell. In terms of cost, well, I'm not the owner or developer, and I don't have any shares in the system. So I think I don't necessarily want to speak on behalf of those companies. They are companies. So I imagine that there is a cost involved, but I think it would be best to talk to them. For our research projects, it has been very reasonable.
Okay. Rick, are there any potential unanticipated consequences that we should be aware of when integrating PROMs and PREMs in acute care for older adults?
Yeah, I think that relates to the measurement validation framework that I ended up with. I think that area needs a lot of research. And I'm not talking about just statistical research, but I'm talking about kind of integrated knowledge translation type of research, or implementation science, or translation science, if you wish, to actually really figure out, what are the consequences of using this information. We can think quite hypothetically, quite easily, that every instrument is based on a value base, and it includes certain questions and doesn't include other questions. And by doing so, certain things are made visible and other things are not made visible, just by the selection of the instrument that you choose to use. And so that does have implications. In addition, we've seen that there's challenges regarding the translation and cross-cultural adaptation of these instruments. And so if we don't take that into consideration, I think the needs of people who are from different backgrounds may be inaccurately represented, and that would be an important unanticipated consequence to consider. But there is potentially many more, and I think it's an important area for both research and theoretical philosophical thought to tease that out. But I've given you some examples.
Okay, one last question for you, Rick. Given the centrality of patients and family caregivers in PROMS and PREMs, what might be the role for patients and family caregivers in validating the tools as aligned with their values and goals?
Yeah, that's a really good question, and it actually relates to again the modern view of measurement validation that I've been talking about. Many of the instruments have been developed with consultation of patients and family caregivers. So, you know, typical approach is that there's kind of focus groups figuring out what are the typical needs, and then developing items to measure those needs, and then getting feedback from them as to whether those questions or items accurately represent their perspectives. But that is typically in the measurement validation stage, and like Eric pointed out, there is not very many studies that focus specifically on older adults, and there's even few that focus on family caregivers. So what is their role? I think there is that piece in the developmental stage of the instruments, but considering that we already have 1,200 instruments out there, I don't think there's a lot of appeal for developing even more instruments. So there's more figuring out as to what the instruments measure and whether they need to be slightly adapted to address and to accurately represent the perspectives of patients and families. And within that context, I think the patients and families really need to be invited to be part of what I would refer to as integrated knowledge translation work, where we work together in figuring out both the selection of instruments and coming to a common understanding as to whether the extent to which your questions have meaning to patients and families, and also the other knowledge users, of course. And so it all needs to come together. And so for that to work, I think it's imperative that patients and families become actually integral parts of the research teams. This is not like the past approach has been kind of, they're a group that we go to get some information, and then we come back to our team and do our analysis. I think that's not enough. We actually need to integrate them right in the analytical process to ensure that their needs and perspectives are accurately represented. Ultimately, that's what it's all about. So as you can see, I'm quite passionate about that. Happy to talk about it some more. Thank you.
John?
Yes, so thank you to our presenters, Dr. Sawatzky and Dr. Chan, for very informative and very interesting webinar. And it's certainly great work, and I look forward to seeing some of the future work on this in the past. And I think the more we focus on these measurements, I think the more that we can actually improve the healthcare system. I'd like to thank you all for those participating and for attending today's webinar, for taking time out of your busy schedules and being involved with TVN. At the end of this webinar, there will be a very brief feedback survey will pop up on your screen. Please take some time to provide some feedback on today's presentation, and also feel free to provide your opinions on how we can continue to improve the TVN Webinar Series. We've been having these webinars monthly, and we can expect to continue them on into the indefinite future. Also, if you have suggestions as to topics for webinars, or you have some webinar that you would like to present, please let us know, and we will try to schedule you in. We're currently scheduling webinars for 2016. Thank you again for paying attention to the feedback survey that pops up. Our next webinar will be July 22nd at 12 noon. This has been one that's been rescheduled since normally our webinars are the first Wednesday of every month. The next webinar is on post-discharge rehabilitation interventions for older adults with cognitive impairment following a hip fracture. It's by Catherine McGilton at the Toronto Rehabilitation Institute, and Paula Van Wyck at the University of Windsor. Please follow us on Twitter, and the webinar slides and the actual recording of the webinar itself will be available on our website. Please please come back and refer to the slides when you have a chance, and also please refer them to other people who may be interested. So thank you again. Thank you again to our presenters. Thank you for attending, and please tune in for the next webinar in a couple of weeks. Talk to you then. Bye.